So we're going to start our portacath today. First thing that we want to do is always with any time we go in and out of a patient room is doing the hand hygiene, which includes hand sanitizer, scrubbing for 15 to 30 seconds, or washing with soap and water at the sink. Once that's done, we'll go ahead and get started on Princess Fiona. Hi Princess Fiona, this is Jen again. I'm just here to come start your portacath like we talked about earlier. Before I get started, I wanted to check and ask you how long you've had your portacath. At this point she'll tell us how long have you had your portacath, where was your portacath actually placed, and if it was here, that would be wonderful. All these are things that we want to document in our charting. The other thing is, how long ago was the port flushed with heparin, where they access it with the needle and flush it with heparin, make sure that it's running smoothly. And if she's had any other problems with her portacath. Would this be an okay time for me to start your port? Okay, sounds good. So next thing I want to talk about is most of us hopefully have seen a port, but for those who haven't, this is one of the ones that we have, that we actually implant here at our hospital. It's the Purple Power Port, as most people are familiar with it. It goes underneath of the chest. There's usually a little section that they cut open and make a little tunnel for them to place this port, part of the port underneath, and then they run the line underneath of the subclavian and into the superior vena cava. The biggest thing with these ports that we like to be aware of is there's three little dots. They stand up a couple of millimeters, making it really nice for us to be able to locate where the port is. The port is pretty superficial, just a couple layers under the skin, so you should be able to actually feel the triangle of the port. And then depending on the position or how long the patient has had the port, sometimes you're able to identify these little 3-dot landmarks. On the back you can see also there's the triangle. In the center of the triangle is generally where, when we use the Huber needle, you're going to go right into the center of the port, and you want to feel the back of it a lot of times when you're accessing. So when you push the Huber needle in, you'll want to hit all the way to the back. It won't go through the back. Won't go out any other sides or either. Additionally, there is little marks on the port that the surgeon uses to attach sutures while they're in the OR to stabilize this. So it really should not go anywhere. When you feel it underneath of the skin, sometimes you can move it around, but it shouldn't travel anywhere other than a couple little centimeters and underneath of the skin. And if it is traveling further than that, you want to stop immediately and call the doctor. Once that is verified with the patient, you'll want to make sure to check to see if she has any allergies. So Princess Fiona, do you have any allergies? Making sure that she doesn't have an allergy to alcohol swabs or chlorhexidine, since those are the two products that we use the most. Additionally, in our kit we have normal saline that we use to flush, and we also use lidocaine to numb the area before we actually access the port. So if she does have an allergy to lidocaine, you'll want to make sure that you do not use any of the lidocaine or the cane products. From there, we'll go ahead and get started with setting up our sterile field. There are these nice little kits that are usually pre-made, and on the chemotherapy cart they should have all of the supplies that you need to access a port contained within them. It's never a bad idea to check and make sure everything's in there. There's a list on the chemotherapy cart that says what should be in each kit. You just want to make sure that once you start the sterile process, the sterile opening of all the equipment, that you don't leave the room. So if you don't use these very often and you can't tell at a glance that everything's not here, you might want to go through it and just double check. It'll save you time and hassle in the long run. And the lidocaine is not in the kits. So you may need to get this from Neil in the pharmacy or if we have any in the med rooms, making sure that if they've already been opened that there's a date on there and that it's not more than 28 days having been opened. If it is, you need to discard it in the correct bin and open a new one. This one is just a few days ago, so we'll go with that. Before I even start to open anything up, I like to make sure I've got a bedside stand nearby, that it's clean with either the purple swipe cleaners or the Clorox ones, and you'll want a garbage can close by. Again, once we start opening the sterile equipment, we don't want to turn our back on our sterile field, so keeping these kind of close together is going to save you a lot of hassle trying to keep things contained. So we want to make sure that if we touch anything as we're moving our supplies closer to the patient, anything that we touch that's not part of the supplies, we want to repeat the hand hygiene protocol series. So hand sanitizer 15 to 30 seconds or washing our hands again at the sink. We want to protect the patient from getting any kind of infection. Again, this is a sterile process. So I'm going to do my magical surgery here. Personally, before I even bother opening my sterile equipment, I like to check and see where the port is at. Ask the patient which side is it on, left or right, and then you usually can see the little surgical incision. It's about 2 inches just above where the pocket was made to place the port. In this case, she said it is on her left side. I see the surgical line. I'm going to feel around for it, seeing if I can identify the landmarks, which is that big purple triangle or the 3 dots in the center. So I found the triangle. I'm going to pinch it there, trying to feel for the dots. And I don't really feel the dots, and that's not particularly uncommon. Just depends on the patient and how long they've had their port in and how their skin has been able to tolerate the port. One good thing to keep in mind is once you've identified that port site, it's not going to cause the patient any pain when you're holding it. If you're cramming it down, yeah, it might be a little bit uncomfortable, but to simply hold it there in your hand to keep it really steady, it's not going to cause them any undue pain. And ideally, you want to do that so you don't have to make more than one poke attempt, especially with this type of a needle that we're going to be using, which is the Huber needle, and it's 20 gauge. So I've identified, yep, her port's there. It's not moving all over the place. It's just a little bit of give. So now we'll go ahead and start with our sterile field. So if you are going to do labs, you want to make sure you have the correct color tubes. The labs open, you can give them a call, 6372. I know personally that in the chemo bags we have the purple and the green top. The purple is for CBC and the green top is for a BMP, a basic metabolic panel. Those are the most common ones that we're going to use. So you want to make sure you've got the correct collection tubes with you. Just saying that because the chemo bag comes with those. So if you are doing it out on the floor and you've got different ones than what I just said, you want to make sure to clarify in the labs. Additionally, in the port accessing kit, there is a blue vacutainer blood collection device. Blue meaning this little tip right here. This is the one that we will actually connect to the Huber needle tubing, and then from there what you'll do is you just put the blood collection tube into the opening there, and I will demonstrate this, and it will vacuum the blood directly out and into the tube, and it will stop when it's complete, and then you can take the tube out and put in whatever other labs you need to have drawn. The red one, on the other hand, or the pink one, it differs in that it's a luer lock on the outside. So this is used in cases where if the blood you're noticing the port is sluggish and not really flowing or pulling blood back very easily, you may want to just go ahead and use the 10 cc syringe technique where you pull the 10 cc's of blood out and then you will connect the syringe right onto the base there and use it in the same method. You'll connect the tube into the vacutainer and the blood will automatically pull and push into the tube. The chemo bags only come with the blue one. There is the pink ones also available if you think that's going to be a problem or has been a problem. It's on the chemotherapy cart. So now we're going to go ahead and open our supplies. Reminder, this is a huge emphasis, very heavy, on this is a sterile process. We don't want to contaminate our sterile field. Once we've set it up, do not turn your back. Don't lean over. Don't touch anything on the field once it's set up until you've got sterile gloves on. We do not want to get the patient sick. So, I'll put my mask on. That's one of the first things in your kit that you should find. I also like to adjust my table so that it's in the best possible position for keeping my sterile field close to where I'm going to be working. So I adjusted that there, moved my garbage can so it's still close by where I'm not going to be contaminating anything. Take your first sterile drape, grab it, pinch it by the edges here, raise it up, throw that in the garbage. Only want to try and touch the edges of your sterile drape here. Kind of getting it open. And then you'll set it on the edge of your table there, just like that. Making sure nothing is touching the edges. I also like to set up the second sterile drape, which is going to go across the patient's chest so you have a little sterile work area. So again, you'll grab the edges of the sterile drape, shaking them out away from you, and not crossing your sterile field. If the patient has garments on, you can ask them to unbutton it or move it out of the way. You'll tuck just the edge underneath of the patient's garment, away from where the port's at, giving you plenty of space to work. And that way all of this area is now sterile without crossing over it with your body or your hands. I'm going to keep my gloves to the side. And then you can open up your supplies. The easiest thing is making sure the edges of all supplies, sometimes they're kind of taped on the ends. You'll want to break those before you get started with opening them. You open away from your body. And you'll want to slide it onto the field. When I open a big item like this, I was able to use the sterile side of the package, running it against my forearm like that, so anything that goes over is sterile to sterile. So that's one trick that's nice if you've got a big item that you're opening and it's got something small inside like that thin bio-occlusive. It can go flying all over the place and sometimes it's hard to get out. So by being able to use that to kind of guide your forearm onto the table is a great tool. All the other ones, again, you'll want to open the package away from you, popping it onto the sterile field. Sometimes some of the equipment can get kind of stuck, or if it rips anywhere along the package, you want to discard it. That's no longer sterile, so you'll need to call and get some extra equipment. And one of the things that you want to do, if that does happen, is if the call light is close to the patient, which in this case we do have it in the patient's lap, their hands are underneath of the sterile field, you can ask them to push the call light, and once the nurse's station calls, ask them to send somebody in with the equipment that you're needing, or ask them to send somebody down if it's too hard to describe whatever the equipment that you need is. Just continue to open things in the sterile manner. If that happens, you'll want to call and get an extra one. Happens. You can even go closer to avoid that from happening and prevent it from happening. lower you can get to your sterile field, sometimes it makes it easier to get things out of the package. And you do use all of the supplies. It does look like a lot, but they're all there for a reason. Sometimes patients will ask if you really do, and you do. Sometimes things will get stuck. You kind of have to work with them while in the sterile package, or just start over and get another sterile piece of equipment. Again, some of the packages are kind of hard to open. These are our new power ports. On the back, it will give you the information. They're 20 gauge, 1-inch needles. That's what we carry as our standard now. They are power ports, which means that once you, after we make sure that the patient has a power port to begin with, we need to verify the manufacturer before they go through a CT scan. If they've had their port placed here, which a large percentage of the community has had it placed here, and recently anyway, you want to make sure it's the correct manufacturer before sending them through the CT scan. And our Huber needles are also power port approved. So once you use this, it is the only kind that we have on the floor anymore. If you do access a port with this, it is one that can be used for CT purposes, for contrast. There's information on the front that you can rip off that also describes how to access a port, and that detailing that it is a power port Huber needle. That. Even though I just popped it off, always a good habit to go ahead and cleanse the lid. Gonna do that really good with our lidocaine as well. Now we're ready to go ahead and get started. If this is too close of an area to start port with your gloves, because remember you're going to open your gloves open in a sterile fashion, you can use part of the patient's bed if it's in the same proximity without going over, or if you have another stand or a table or something else close by that you can utilize. Otherwise, you want to use extreme caution and bear in mind this is also part of the sterile procedure, opening the gloves. So we'll get started. So for the purposes of this video, I've taken my mask off so that it's easier to speak and more clear. You would never do that in real life, ever, ever, ever with this procedure. So just a little heads up. So we'll go ahead and get started. Since I'm in a situation where there's no other surface around, I'm going to show how you would open the sterile gloves while still keeping your sterile field. I'm going to just turn them to the side here, making sure you don't trip. And you flip open the sides of the gloves, tugging on the corners, keeping them nice and open. I like to start with my right hand. Remember, with sterile gloves, this inside, they're cuffed inward, so the cuff part of the gloves is not sterile. Once you start working with it, it's not sterile. So you can use your fingers as you need to kind of open it up, slide your hand in, and these gloves that we use for our sterile procedures, they're kind of sticky at times. So you might not get all your fingers in on the first try. You'll get it fixed. You'll grab the lip to pull the glove all the way up. You'll go ahead and grab with your sterile hand, trying to get under the cuff, to kind of give yourself something to work with here. And then with your unsterile hand, start to get your fingers in. Flip your hand. And now that your hands are sterile, you can touch the sterile part of the gloves to get your fingers in, to get it nice and comfortable. Fix any fingers that are in the wrong holes. You're done. Your hands are sterile. That part of the glove container is sterile. So you can pick it up and toss it. Don't care where it goes because you're sterile. Gonna slide back over to the patient. First thing I like to do is get all of my instrumentation that I'm going to be using set up. That includes using this vial adapter here. It's very sharp. Use both hands because this top portion, there's a little disc. Here there's a little disc. Anything above that is going to be sterile. Anything below that is going to be unsterile once you spike the bottle. So I use both hands because it can be kind of difficult. And you spike the normal saline bottle. And take your hands off. Next thing I do is I grab one of my 10cc syringes. I take the bottle, pinch with the blue with my fingers, connect. It's lure lock. Everything should be lure lock except for your TB syringe and your power port syringe. You'll drop 10 milliliters. Try and get all the air bubbles out. With the first syringe, set it down. Second syringe, drawing up 10 milliliters. 10 milliliters. And third syringe, 10 milliliters. Once that's done, you can set that out of the way. Set that down there. I'll set up all the pieces of the power port next. The biggest thing I've always gone by is once you have a routine, always do things the same way every single time. That way you're not going to mess up, you're not going to miss a step. You'll know almost immediately if something's missing if you follow the same pattern. So I grab my power port, I flip off the top that I tossed in the garbage, or you can leave it on a corner of your stand if the garbage isn't close by. There's the another one of the adapters. It's like a vial adapter for tubing. You take the blue part off. That opens up the lure lock, so these will just twist together and on. Make sure it's on nice and tight. Grab one of your 10cc syringes, connect it. You want to flush it before you even get started. Get it primed. You've got a little wet spot of prime there. Loosen the needle protector on the end to make it a little bit easier. I set that in my corner. It's ready to go. Next thing, got my little vacuum container. Keep that close by. I'm going to go ahead and get my lidocaine ready for injection. You've got your TB syringe. You take the cap off. I put 2x2s, line them up here. I open each one up and stack them like a little sandwich. Wrap it around the vial, making sure to not touch the plastic with your gloved fingers. If you do, you need new gloves and you need to change them out to become sterile. I'll flip the vial up, poke. Usually if it's a TB syringe, I use 0.2 mils of lidocaine. I draw up that much, gives me enough to work with if I need to really numb up the area. Set that aside. No worries. I'll gently put the cap on so I don't stick myself or anybody else in the meantime. And now we'll go ahead and start. We've got our Tegaderm here, some extra 2x2s. Now we'll use the chlorhexidine cleaners. There's 3 of them. You break it by squeezing the little flaps together. You'll hear the snap. You should start to see the water coming through, or the fluid. You'll tap, 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 tap to get it so you can see that it's moist throughout the entire thing. You can see it on your glove, nice and shiny there. Once you've got that, depending on whatever hand is your dominant hand, you have to make the decision at this point because you're going to be holding down the port once you finish sterilizing. So, and you really don't want to move your hand from the port at that particular time. So, start with your chlorhexidine. The first one, you're going to go in a circular motion around, 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 and you go outward. And you'll toss. Tap, 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 tap. Again, circular from the inside, going out. If you don't have a garbage, again, you'll make one area your designated contaminated, dirty area, and don't go near that area. Tap, 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 tap. Scrub. And I personally also like to wait for that to dry. It takes a couple minutes. It's okay to converse with your patient. I want to make sure it's dry before I inject lidocaine. It's going to sting already, so I really don't want to cause an additional pain to the patient because it can be discomfortable if the chlorhexidine and the needle and the lidocaine touch. So I'll get my needle already aligned so that the bevels face up. Looks like this is all dry, so I'm going to find with my personally non-dominant hand where the port is again, making sure to hold it down with my fingers. I like to use a triangle method, so I've got my middle finger on one end of the triangle, my index finger on another, my thumb is on the other, making sure that I'm not pushing my hand down like that, because then I'm contaminating. So this is another angle, so you can see up close that I've got my middle finger really holding down one end, my index finger on another, and my thumb is on the other side. You can use your gloved finger, since this is all sterile with the chlorhexidine. See if you can feel where those 3 bumps are, and I can vaguely feel where the bumps are. So you'll keep your hand like that. That's going to be your anchor hand. Again, this is the trick to getting the port each and every time, is making sure you really have good control of that port. So it's not moving around and that you're not trying to go for a moving target. Just like you would a TB injection or any other subcutaneous, you're going to go gently under the skin. Here we go, little poke, 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 poke. And here comes the numb shot. You might feel the numb. And so you'll inject the numb lidocaine. You'll start to see a little bevel come up, a bleb. And you can, do it slow, give it a couple seconds, go at a different angle, go a little bit deeper, inject a little bit more. And once you see a really good bleb and you've either used half or the entire amount of the lidocaine that you've drawn up, you can pull it out. Remember, put the safety on. Without moving that hand, so I've got good control over it, I'm going to release the safety plastic off of the Huber needle. Personally, I like to have good control, so I wrap it around without contaminating anything. So I've got good control of my needle, and I'm not going to have it pulling or tugging with that 10 cc syringe on the end. This sterile field should be nice and sterile for us. So next what I'm going to do is I will really anchor it down, putting a finger there, and you will go in. Here comes the big poke. 1, 2, 3, poke, and you go down hard and fast, straight in. Hold on to the little butterfly once you're in. If you didn't feel the needle bump against the back, you can push down on the needle. Sometimes you'll feel like a little click, or the patient might say, oh, because they can sometimes really feel once it's in. From there, I'm going to make sure it's out of the way there, sterile field's down. You're going to flush in the 10 cc's of fluid. It should go really smooth. If it's not, if you're having a hard time and there's good resistance or you can't get any at all, you want to stop immediately and see if you can push it in. You can even feel around where the port is to see if you're right in the middle. Sometimes you might be on the edge. In that case, you'll take your little wings, pull back just a little bit, just a little, enough to kind of pull back, and then you'll angle it to whichever direction, and you push in that couple millimeters to centimeter back in. If you feel the click, then sometimes that's all it needs. It's just a little minor readjustment, and then you'll try it again. Oh, look, it's flushing great now. Once you flush that in, you always want to check for blood return. So you're going to pull back on the syringe. Oh, look, there's great blood return. Since I'm going to do labs, I'm going to drop the full 10 cc's. And then I'm going to hold it there. I'm going to leave it on the sterile field here. I want to secure this. I want to tape it down. Our old ports had a bio patch underneath of it. These new ones do not. Okay. Since there's no bio patch that goes underneath of the port between the skin and the Huber needle, we're going to just go ahead and tape it down. So you'll use your bio-occlusive, making sure the Huber needle is directly in the center, down, and I'll secure right around it. Secure, secure, secure. Trying to make sure there's not a whole lot of lines and crinkles in the tape. Integrity of the tape. You'll see that it is a little bit, there's some air in between where you've taped it down and where the Huber needle is. That's normal. That's just fine. Now the sterile part's over. You can go ahead and peel off the rest of the dressing, trying to avoid the nipple. It can be very painful to the patient peeling these kind of bio-occlusives off. So you want to be conscientious of the nipple, trying to avoid that. And if they have hair, it's okay to shave and clip their chest before we put the bio-occlusive on, and before we even get started, clip it down, because this can be very uncomfortable to the patient. Now that that's secured, we see that you pulled back the blood, the 10 cc's of blood. That's going to be our waste. So you take that, it's your waste one. Keep it away from anything else that you're working with. Since it flushed great and I had fantastic blood return, I'm going to hook up the blue one. Grab the pink or the purple one first. You always want to do the metabolic panel last. So if it's the VMP or the CMP, that tube you want to be the very last one to be drawn. So I'm going to start with the CBC. Going to connect it and just push it together. You'll see the blood starting to fill up in the chamber. And you'll see when it's stopped, it'll slow down and it'll eventually stop. With this, the CBC, there's no preservatives in it to keep it from clotting. So you gently agitate it back and forth just a little bit. Set that down. Grab your next tube, connect it. Once it's complete, pop it off. Out of good habit, you can do that. It's not necessary. Now we'll go ahead and flush the port. So you'll take that one off, put on the 10 cc syringe, flush. Flush is great. Take the next one, flush, and you want constant good pressure. You don't want to push really, really hard, because it can blow or cause discomfort to the patient. Sometimes it can blow the port tubing. You don't want that. You don't want the patient to have to go through that again. So gentle pressure, vigorous pressure. And then as you're pushing, you'll want to click the alligator clamp once you're done with that. Disconnect it. If you're going to connect IV fluids up, you can do that right away and connect it. If you're not, if you're using this strictly for access on an as-needed basis, you'll want to tape the tube down so that it's not hanging all over the place. You don't want it to have a chance to rub up against everything in its path. And I put, our port kits should have the information on the back of the bio-occlusive. I always have a backup one that says my name, my date that I access the port, the time that I access the port, and then you want to make sure that you put the gauge of the PowerPort Huber needle on there as well. If you didn't toss this away already, you can fill up that out right there and you attach it onto the patient. If for some reason the port is not giving you blood right away, you'll still want to attach the bio-occlusive so that the sterile part of the procedure is done, and you know by feeling that you got to the back of the port, that it's flushing really easily but you're not getting blood back. Those are indicators. Go ahead and tag it down with the bio-occlusive, and then that way the sterile part's done. Next, what you'll want to do is use one of your 20 cc's of sterile water or sterile saline that you have here. Try flushing by being a little bit more vigorous. So you'll want to unclamp the tubing, connect one of the 10 cc's of that sterile water or sterile normal saline, and then you'll use heartbeat pulses. So kind of a little bit more vigorous, but not using all of the force that you've got in your body. So you'll do a little heartbeat pulse, 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 pulse. And then try again. Oh, still not getting blood return. Okay. Next what I'm going to do is, Princess Fiona, can you do me a favor? Since your port is in the left side of your chest, can you turn your head to the right? And she'll turn her head to the right. Take a deep breath and cough for me. Really good cough. She coughs. Try pulling again with that. If you start to see blood in the tubing, coming back kind of slowly, have her do it again. See if she can cough again for you. And then keep trying to pull blood back until you see a continuous blood and it comes very easily. Let's say it's not coming back. So next what we can have her do is we can have her raise her arm above her head. This time it's going to be, since it's in the left side, we're going to have her raise her left arm above her head. Because it can be a positional thing. That tube can be sometimes curled, it can be just kind of going in a different direction or sucked up against the wall of a vessel. So changing your position sometimes can help. Again, she's not sterile anymore, so she can put her arm up above her head or lay it up above her head. Try flushing in, pulling back, taking a cough, a deep breath, and a cough again. If that's still not working, we can actually have her recline in the chair, kind of get her tipped on her head. If you're in a bed, you can have them just put the head of the bed down. In this case, we'll flip it backwards. Try to flush, pull back. Oh, still not getting it. Keep her arm there. Have her try coughing a couple more times. Still not getting it. I'll use the other 10 cc syringe of the saline. And I'll try again doing that pulsating push, 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 push. Try it again. Cough for me. Oh, look, it's working. We have blood return. So I don't have any other syringes here. So I'm going to pull back on this. We can use, since we hadn't used it yet, since she didn't have blood return, use your blue collection tube. Grab the blood that way. And then once you're finished, you can disconnect it. Since you're not sterile, you can go and get a saline flush, a regular saline flush, which I don't have any in my pockets at this moment, but we all know what those are. You'll site scrub with alcohol or with alcohol. Scrub that port right there really good. Use the saline flush. Clamp it off once the blood is out of the tube and the saline is done. Let's say you still didn't get any blood return and you did all of the techniques, you tried everything. Well, now it's time to call the doctor. So you'll want to clamp off the tubing here. Get the patient comfortable. See how she's doing, if she's in any pain or having anything else that's undesirable. Let her know, here's your call light. I need to go call the doctor and let him know that your port's not getting me blood back. See if he wants me to go ahead and instill some cath flow, which is one of the more common things that we use. It's a TPA agent to try and unclot or break off some of the fibrin that can collect on the tip, the end of the purple tip, causing blood return to be very difficult. So she's comfortable. I'm going to go call the doctor and get an order for that cath flow or see what he wants us to do in this situation. So I'm going to go ahead and wash my hands with hand sanitizer. So we're back. We got doctor's orders to say to go ahead and give the clot buster cath flow. On a side note, we do have several different kinds of medications or different quantities and dosages of some of the medications. So you want to be very specific. Typically with the PortaCath, we use the 2 milligrams per 2 milliliters of cath flow. So with this med, you do need to reconstitute the medication. It'll come in a powdered vial. Generally, cath flow is kept in the refrigerator, so that's another indication that you want to use it in a timely manner as well. One of the things with cath flow, if you know the patient has had to have cath flow before, if they've had fluoroscopy to check for tube placement to make sure it's actually flowing in a correct manner and it's in the right spot, you may want to go ahead and ask for the order to read something like this. Cath flow times 1, IV push, 2 milligrams is the actual dose. May repeat times 1 if first attempt is unsuccessful. The maximum number of times that you can use cath flow is twice. So it is never a bad idea to have that secondary one as a backup, making sure that you've got that clarified in the order since we don't have a standing order for cath flow and its usage. We've got the order, we got it all checked off, pharmacy's done what they needed to do with it, they've given us the medication. I don't actually have the real medication vial, it's small and has a purple lid, the one that we are currently using. But you'll check the bottle as you would anything else. Cath flow, oh, it's 2 milligrams. Anytime you're using a medication that you're not familiar with, you always want to check the manufacturer's information. It's important to know what you're giving to your patient before you do. I've highlighted on here the instructions for administration. In order to reconstitute the powder, it's going to require 2.2 milliliters of sterile water. Do not ever use bacteriostatic water or normal saline. It says you want sterile water only. I'm going to go ahead and do that. I'm going to pop the lid off my cath flow. Since I know it's going to be 2.2 mils, I'm going to actually take a 5 milliliter syringe because with ports, you want to make sure there's at least 5 milliliters of pressure. You want to syringe 5 milliliters, 10 milliliters, 20 milliliters, something greater than just the 3 ones that we have. Keeping the end sterile like you normally would drawing up a medication. You'll connect it with a syringe and a needle. In this case, it's an 18 gauge needle. I'm going to go ahead and insert. Since I just popped the tops off, you don't have to clean with with alcohol. You can, but it's not necessary. Getting all the bubbles out. Again, I like to check, make sure as I'm drawing up the fluid, oh, this is sterile water. It's not expired, and you're going to draw up 2.2 mils. Now I'm going to inject it into my cath flow. Inject it slowly. It can cause foaming, so you'll want to inject it kind of slow so it will dissolve. If it starts to foam, you just want to finish injecting the sterile water and let it stand for 5 minutes. And it actually does say that in the instructions. So slow is better. And then you'll gently agitate it around. Just roll it gently until all of the medication is dissolved. And then you'll draw back up the fluid. And you'll draw it until it's empty. You want to make sure it is just the 2.2 mils per the manufacturer's guidelines. And you'll flip the top there, so now you can take it into the patient's room. I also made out a label on here. It says the patient's name. It says the solution. It's going to be cath flow. It's an IV push medication. I always make a little label, you know, we've got the date and the time and when it will expire. I say do not touch because I'm actually going to leave the syringe connected to the port with this little label on it. So if anybody comes in and they're wanting to mess with the port or the IV, that's kind of an indicator. If somebody leaves a syringe with a label that says do not touch, there's a reason it's there. We don't want anybody pushing fluids in right after this because it is a clot buster and you don't want to be pushing something like that unnecessarily into the patient's body. So I got my little label on there with the correct dose. It says 2 milligrams. Everything's correct. So we'll go ahead and say, Princess Fiona, I've come back into the room, washed my hands, done my hand hygiene. Princess Fiona, I've called the doctor. He said he wants us to give you something called cath flow to see if we can get that fibrin sheath off of your tube so we can get some blood back. Would that be okay? She said, yeah. We're going to go ahead and cleanse the port hub here, the catheter cap. Scrub really good. I'm going to hold it there so it stays sterile. And I twist off that just like you would any other medication. Twist it on. Unclamp my clamp. And you'll just slowly push it in. Making sure that once you're at the end, you want to clamp that off. Keep the pressure there. Oh, excuse me. And I'm going to leave that attached. Once again, that's a sign for anybody else that comes in the room not to mess with that. That's not normal practice that we do with any other medication. So, with this, again, you want to follow the manufacturer's instructions. You'll already know if you've reviewed this that you want to wait at least 30 minutes. Give it time to dissolve and break apart any fibrin. It's 30 minutes. Princess Fiona. And hygiene. Princess Fiona, I'm going to go ahead and check your catheter here and see how the PowerPort FortiCath Access is doing. Is that okay? Okay. Unclamp. We're going to try and draw back. At this point, if you see the fluid, you want to at least get the 2 mils of clear fluid out. You may even see blood coming back before then. So you'll just keep drawing back. You want to try and get every little ounce of that out. So either a 5 or a 10 cc syringe, you want to get at least 5 to 10 cc's of fluid and or blood out. And we see blood coming out, which is fantastic. So then you'll disconnect that. And then you can connect your attachment to get the blood transfer so you can collect your blood at that time. If you don't need blood, then what you can do after this is you'll go ahead and use 2, according to the manufacturer's guidelines, 2 normal saline flushes. So they're 10 cc's a piece. So you'll do one and then the other one, and then you'll clamp it off or connect her to the IV fluids if needed. If you still don't have blood coming back, and let's say you just have a little tiny bit of the fluid of the cath flow coming back, that's fine. It's nothing to get panicked about. That happens. What you'll want to do is wait another 30 minutes, check it again, and you can use the medication again, the second dose. If you had it ordered, you'll do the same thing. Grab another cath flow, mix it, reconstitute it, and then at the 120-minute mark, you can go ahead and try it again. You'll instill it, wait 30 minutes, see if you can pull back. Try the coughing, the turning the head sideways, raising your arm, flipping the patient back. Try all the tips and tricks if it's still not pulling back. And if you're still not getting blood, you want to call the doctor again and let him know that he or she know that you've attempted cath flow ×2, we're still not getting a response. And you really do want to give it at least 30 to 60 minutes. If at the 30-minute mark it's not pulling back, give it another 30 minutes and check it again. Sometimes it will start to pull blood back after that point. So you'll either connect the patient, if you do get blood and you've been able to collect a sample, you can connect them to their IV fluids, or you can saline lock them. Or you'll call the doctor again and ask for further guidelines. All done.